All right, welcome to this explainer. Today, we're stepping straight into a high-stakes clinical courtroom. You know, in pediatric gastroenterology, time is quite literally tissue. Misdiagnoses here, they aren't just minor errors. They can be totally catastrophic. So we're going to conduct a strict clinical audit of the absolute top gastrointestinal emergencies.
Let's dive right into the docket. We've got four main things on the agenda today. First, the ectopic mucosa trap. Then, ligament of Treitz physics. Third, the 48-hour meconium gate. And finally, an executional pearl on abdominal wall defects. Let's get to it.
So, I want you to keep this one crucial question in mind as we go through this. When an infant's gut fails, are you looking at the signal or just the noise? Pediatric GI exams are honestly absolutely full of distracting noise, crying, overlapping symptoms, serious parental panic. Our entire goal in this explainer is to train your eye to cut through all of that and audit only the true definitive clinical signals.
Okay, moving right along to Section 1, the ectopic mucosa trap.
Picture this. A 2-year-old comes in with blood in their stool. It's a classic 50-50 dilemma, right? On one hand, we have Meckel's diverticulum, which is a remnant of the vitelline duct-containing heterotopic gastric mucosa. The signal here, it's painless, massive, brick red or maroon bleeding. Why? Because acid is actively ulcerating the adjacent ileum. Now contrast that with intussusception on the other hand. This is a telescoping of the bowel that causes venous congestion. The signal here is totally different. It's episodic, knees-to-chest colicky pain and a late finding of current jelly stool, which actually represents true mucosal ischemia.
Now, if you look at a cross-sectional ultrasound, intussusception reveals this incredibly classic target or donut sign. Seeing those concentric layers of serosa and mucosa, that is your absolute green light for an air enema. It's brilliant because it's both diagnostic and therapeutic, all at once.
Let's switch gears back to the high-yield signal for Meckel's. You absolutely must know the rapid-fire rule of twos. Check this out. It occurs in 2% of the population, it's located 2 feet from the ileocecal valve, it's exactly 2 inches long, and it contains 2 types of ectopic tissue, gastric and pancreatic. That right there is pure signal. You need to completely ignore noise like, say, a palpable olive-shaped mass. That points to pyloric stenosis, not Meckel's.
Now, I have to issue a severe trap warning here. It is a massive, incredibly dumb mistake to order a standard CT scan or ultrasound as your first-line test for a suspected Meckel's diverticulum. Standard imaging is notoriously blind in this specific scenario because that heterotopic gastric mucosa will evade it entirely. You're just going to waste precious time, and remember, time is tissue.
So, what's the fix? The absolutely crucial point here is that you must order a Meckel's scan. This is a scintigraphy scan using technetium 99M per technate. Why? Because this specific test definitively hunts down and selectively labels those exact ectopic gastric cells. That is exactly how you execute on this diagnosis.
All right, heading into Section 2, ligament of Treitz physics.
Let's look at how a seemingly simple case of failure to thrive can just suddenly shift into an acute mesenteric disaster. In normal anatomy, the ligament of Treitz safely secures the duodenum to the left of the midline. This gives the mesentery a nice, broad, stable base. But in malrotation, the cecum gets stuck up in the upper quadrant, and these fibrous lad bands cross the duodenum. This drastically narrows the mesenteric base, basically creating a fatal pivot point that can immediately snap into a catastrophic volvulus.
If you order an upper GI series and you spot this twisted corkscrew or bird beak appearance, guys, the gut is actively twisting around the superior mesenteric artery. Blood flow is quite literally being choked off right at that very moment.
So, we use this severity invasiveness matrix to strictly guide our hand. If the infant is stable, maybe just intermittent bilious vomiting and poor weight gain, your execution is the gold standard upper GI series to check that ligament's position. But if the infant presents emergent with acute bilious emesis and abdominal distension, that's it. That is the corkscrew tipping point. Your execution is an immediate surgical lad procedure to get in there, untwist the bowel, divide those bands, and widen the mesentery.
And here is the dumb mistake. Do not, I repeat, do not attempt to buy time to stabilize an infant with an active midgut volvulus. This is a true do not pass go pediatric emergency. If that superior mesenteric artery is occluded, the entire midgut can necrose in just a matter of hours. You pick up the phone and you call surgery immediately. No hesitation.
Shifting downwards to Section 3, the 48-hour meconium gate.
Descending to the distal colon, we're looking at structural failures. 48 hours. Seriously, burn this number right into your mind. This is the strict, hard and fast biological deadline for newborn to pass their first stool. If that 48-hour window closes and nothing is passed, you must immediately suspect a serious distal obstruction.
When you cross-examine this failure to pass meconium, you're usually looking at two main culprits. First up, Hirschsprung disease. This is characterized by a complete lack of ganglion cells. During a rectal exam, the moment your finger bypasses that dead aganglionic zone, it triggers a sudden explosive squirt sign of gas and stool. Plus, a contrast enema will show a narrow distal rectum and a dilated proximal colon. On the flip side, we have meconium ileus, which is highly associated with cystic fibrosis. Here, thick secretions basically plug the terminal ileum. A contrast enema will reveal a tiny, disused microcolon just distal to that plug.
Now, here is another major trap you've got to avoid. If you're suspecting Hirschsprung, doing a superficial suction biopsy is simply a dumb mistake. It just won't yield enough evidence for a definitive clinical conviction. It's simply not deep enough.
To quote the absolute standard of care here, you must obtain a full-thickness rectal biopsy to definitively prove the absence of ganglion cells. You literally have to get deep enough to prove that those Meissner and Auersbach plexuses are actually missing. Anything less than that, it's just noise and it won't hold up.
Finally, let's wrap up with Section 4, an executional pearl on wall defects.
You absolutely must be able to recognize the difference between these two right at birth. Gastroschisis presents as naked bowel protruding, usually to the right of the umbilicus, with no protective membrane. But the good news, it's rarely associated with other genetic syndromes. An omphalocele, however, is a different story. It traps the bowel inside a peritoneal sac right at the umbilical root, and it is heavily tied to severe genetic anomalies, like trisomy 13, 18, and Beckwith-Wiedemann syndrome. As you can see, an omphalocele is entirely contained within the base of the umbilical cord. That membrane you're looking at consists of peritoneum, amnion, and Wharton's jelly. Seeing this sac doesn't just mean, hey, we need a surgical repair. It immediately raises a massive red flag for associated systemic, life-threatening anomalies.
So what's your definitive execution here? If you see an omphalocele, your next critical step isn't just to wrap the sac and call a surgical consult. You absolutely, without a doubt, must get an immediate echocardiogram. Why? Because you have to rule out fatal congenital heart defects before you even think about taking that fragile neonate to the operating room.
And that brings us to the end of our explainer. In the fast-paced courtroom of pediatric clinical emergencies, are you going to fall for the noise, or will you definitively execute on the signal? Keep your index of suspicion incredibly high, always hunt for that anatomical tipping point, and remember, above all else, time is always tissue. Thanks for tuning in, and until next time, keep analyzing the evidence.